Um, you are more than a brother to me. And I have the pleasure of introducing Dr. Vijay Vishwanathan, who has been working in this field for last so many years. I have ever opened my eyes in the field of diabetic could have found Dr. Vijay Vishwanathan there, and I've grown up listening to his talks. And currently, he is the head and chief diabetologist at MV Hospital for Diabetes and Foot Care. And it's a WHO collaborating center for research, education, and training in diabetes. He is the president-elect 2021 to 23 for DFoot International, based in Belgium, and consists of experts from 193 countries. He's a national vice president RSSDI, and he's completed 29 years as a diabetologist in the diabetology field. And he's a PhD in diabetes nephropathy and published 50 research papers in this field. He's the first Vivian Fonseca Award. He has won the first Vivian Fonseca Award from the American Diabetes Association for his work in diabetes and tuberculosis in 2013. He also developed especially the field of diabetic foot care in India by training over 2,000 physicians in the prevention of amputation, setting up a state-of-art podiatry center in Chennai since 25 years, and published 150 original research papers in the field of diabetic foot. A remarkable achievement, and he has been awarded fellowship of Royal College of Physicians, London, for research contribution in diabetes. In the field, his field of interest is mainly diabetic foot, as is evident from his biodata, and diabetes and kidney in diabetes, diabetes in patients with tuberculosis, and socio-economics of diabetes. Over to you, sir, for your deliberation.
And thank you, Manisha. I'm going to finish in 10 minutes because you took 10 minutes for my introduction. It's a pleasure to.
Yeah, it's impressive and lengthy, sir.
So I'm going to finish in
Long
10
journey.
minutes.
Yes.
It's a pleasure to be with two of my colleagues, Ed Jude and Jay Shah. And I'd like to thank Dr. Banshi Sabu, the president of the RSSDA, for this invitation, and Rohan Patel, who's our student actually, and Dr. Rajneesh for joining as chairperson. So I'm going to finish in 10 minutes. And what I'm going to show you is how a physician can help a surgeon to actually look after wounds. Because when you talk about wounds, people tend to think it is more a domain of the surgeon. But in the next 10 to 12 minutes, I'm going to show you how a physician can be helpful in looking after the wounds. So this is the title of my talk, and we know that. Let me start with a small introduction about what is happening in India. Throughout the 10-12 minutes, it's going to be only about India, what's happening in India and our experience in India. So a lot of amputations are happening in India. We say amputations are coming down in some countries, but in India, during the lockdown in India, I have seen a six-fold increase in the amputations in our hospital, right from March 25th, when Prime Minister Modi announced the lockdown, till yesterday. We have seen a threefold increase in the number of amputations. So amputations are very much happening in India, and this was probably one of the earliest studies I'm looking for my laser pointer. Yeah, found it. So this was one of the earliest studies which we did along with Stephen Morbach and Abbas from Tanzania and our group in Chennai, where we looked at what were the risk factors for diabetic foot amputation, ulceration in about 613 patients from Germany, Africa, and in India. And this was published in Diabetic Medicine about 17 years ago. What we found was infection and bad wound care was the primary reason for amputation among the patients in Tanzania and in India. Now, this was a recent study which we did during the lockdown, where we contacted about 89 diabetologists across the country. And we found that diabetologists treat a lot of diabetic foot lesions, cellulitis, callus, infected callus. About 52% or 50% of the diabetic foot infections were being handled by diabetologists, and they were referring to a surgeon if they could not manage or any debridement was needed. Therefore, a diabetologist is very much a part of the team caring for people with wounds. Of course, nurses and orthotists, surgeons play a very important role, but the diabetologist also and the primary care physician also plays a very important role in India. That is why, way back in 2004, about 16 years ago, along with the World Diabetes Foundation, we started this program called Step by Step, where we trained diabetologists. And I'm happy to say Banshi Sabu is one of them who got trained at that time. And we took doctors, diabetologists, and their nurses from India, Nepal, Bangladesh, and Sri Lanka. And we had Dr. Ali Foster from the King's College and a couple of diabetologists and surgeons from India, where we did this program. And it's very important that we work with diabetologists and diabetic foot. And about 45,000 patients were screened in the first year of this basic course, and about 15,000 of them were identified with high-risk feet. So the diabetologists in help to actually prevent wounds, and trivial lesions were managed by the diabetologist and the nurse who was working with the diabetologist with the help of the training they got from the step-by-step program. Carol Baker mentioned that the step-by-step project, which started in India and then went on to Africa, is now an official part of the IDF, United Nations Resolution Implementation Program, to develop it in developing countries. Now, this was a typical example where there is a confluence, I would say, interaction between the diabetologist and the surgeon. This patient came to us in the month of April, when there was an acute lockdown in India, and came with a pus pointing in the sole of the foot, and there was an abscess there. And the surgeon was kind enough to come and operate. Now, this patient takes to about 2 or 3 weeks to reach this stage where we suture the wound and try to heal the wound. Now, it takes about 2 to 3 weeks, and who's going to look after this period? So it's again the wound, and it's the surgeon with the diabetologist who looks after the diabetes control and also helps in wound management before the surgeon actually does the final act of suturing the wound. This was another patient who came to us during the lockdown. This is not lunchtime, so this is a lot of maggots you see. Maggots in India means dirty wound, and the surgeon cleans it. And so we have a big wound here. So who's going to look after this wound till the surgeon puts on a skin graft? It's again a teamwork of both the diabetologist, the nurse, and the surgeon. And the patient keeps coming to the diabetologist for proper wound care and sees a surgeon also now and then. Now, the fact in India, among the Indian patients, if you use the Wagner's classification, most of them have bad wounds, as you saw in the previous picture. About 63% of people have bad wounds. They come very late, and that is one of the reasons for the high amputation rates about which I told you in Dr. Stephen Morbach's study. Now, this is the multidisciplinary approach given by the King's College, by Mike Edmonds and Ali Foster several years ago. So the physician or the diabetologist has a very important role to play in wound control, mechanical control, microbiological control, which antibiotic you should be taking, whether it's intravenous, change to oral, and so on, and the metabolic and the educational control. Of course, the surgeon plays a very important role in wound control, in vascular control. Of course, we need a vascular surgeon, and so on. So physician plays a very important role in this multidisciplinary approach. The first thing which a diabetologist or a physician must do when you get a person with foot infection is to examine the feet for high-risk feet and look for loss of protective sensation. We have several from Ed Jude's Manchester group. We have the neuropathy disability score. We have so many scoring systems. We have the Michigan system from Eva Feldman, which was used in the DCCT. we can use any of these and make a diagnosis of high risk feet by looking at loss of protective sensation, absent pedal pulses, and asking for a history of a past history of a foot ulcer and so on. We showed in 2001, about 19 years ago, that the Rydell CFA tuning fork is a good device to make a diagnosis of high risk feet. And also, we showed in the Postgraduate Medical Journal in 2002, about 18 years ago, that if you look at the temperature sensation, the temperature difference between that using a tip thumb, using the metallic end and the wooden end, in an air-conditioned room, you can see the difference. So these are all ways in which we can make a diagnosis of a high-risk feet. So that's up to the physician or the diabetologist when a person comes with a foot infection to make a diagnosis of loss of sensation and loss of pedal pulses. Making a diagnosis of peripheral arterial disease is also one of the important things which a physician should do, and he should examine the peripheral pulses and also look for changes in the skin which are suggestive of a peripheral arterial disease and refer to a vascular surgeon. So the diabetologist plays a very important role. Now, talking about the microbiological control, in India, most of the organisms we see are gram positive, but there is an equal proportion of pseudomonas or gram negative sepsis, which occurs in patients in India because they come in very late, poor wound care, and therefore we have a lot of gram negative sepsis, and not to talk about the methicillin resistant Staphylococcus aureus and so on. So during the wound care, wound repair stages, the diabetologist, the physician, can do a lot of things along with the surgeon during the stage of inflammation, which is shown here. And even in the later stages, the physician has to play an important role along with the surgeon. The biofilm is a major cause of concern in India, and 4 in 5 wounds in India have a biofilm, which is often not identified. So it's once again, the biofilm by definition is a group of microorganisms embedded in a thick slimy barrier of sugars like glycocalyx, protein and water produced by themselves. So what happens is if you have biofilms, it's very difficult to manage because it leads to chronicity of the wound. It is difficult to diagnose and it's frequently resistant to antibiotics. We keep treating with antibiotics, but the wounds don't improve and so on. So there the surgeon plays a very important role by frequent debridement using a scalpel. This is what we do in India mostly. The diabetologist and the surgeon should work hand in hand and try to do as many debridements as possible and not leave the job to a nurse to do dressing of such wounds. The surgeon must spend time with the patient and try to do a sharp debridement and remove the biofilm. Now, wound dressings. So wound dressings are very important. Again, the physician must get involved and not just leave it to the surgeon. Many physicians don't even open the wound. They think the surgeon will look after it. It's wrong. In India, people still use a lot of saline gauze, and saline gauze was believed to facilitate wound healing by keeping the wound margins apart and allowing the wound bed to granulate. It was also believed that a dry wound environment would facilitate the death of bacteria. But the management of wound has undergone a sea change in India with the advent of the hydrocolloid materials available from the companies like Urgo and from Coloplast and Smith and Nephew. They have totally revolutionized the management of wound care. And I feel physicians must know the basic dressing materials with these hydrocolloid dressings, which are available in India for about 250 to 300 rupees. They should not give it to the nurses or always depend on the surgeons. The physicians have a very important role, and these moist wound dressing materials, which are available from Urgo and from Coloplast and from Smith and Nephew, will actually produce a shorter, will lessen the healing time, and you can see the patient less often. If you do a saline gauze dressing, you have to see the patient very often. Here you can give the dressing, that's what we do. You can actually give the dressing materials and the patient does it at home. The negative pressure wound therapy is available in India for the past 10 years. And though it's a little expensive, I think it has revolutionized the management of wound care in India. And physicians and diabetologists must know how that works and must motivate their patients to undergo a negative pressure wound therapy because it removes the interstitial fluid, infectious material, and most importantly, it provides a closed, moist wound environment. And in the last 2 minutes, let me talk about offloading, which is very much under the purview of a diabetologist or a physician. So, wound healing consists of multiple things, but one of the most important things is offloading. And in India, we do a lot of total contact cast and the posterior cast in patients. And we also use some orthopedic footwear in some patients. So, what is most important in our country, we have the footwear materials which are available in India, and we can make footwear like this and give them a special insole which offloads the pressure if the patient is fit enough to walk in a footwear. Otherwise, it should be a total contact cast or a posterior cast. When the wound starts healing, you can actually advise patients to wear footwear. We have developed for the last 27 years our own offloading center in Chennai in our hospital, and we are able to provide all the footwears which like the orthopedic footwear and offloading for Charcot foot and so on at a very cheap cost of about 10 to 20 US dollars instead of importing them from Europe. Finally, what do the so it's a mistake. It's not during COVID crisis. It's about what do the international guidelines say about managing diabetic foot. I think we have a special chapter written in the International Working Group on diabetic foot by Frank Game and his colleagues, Applequist and so on. So if I would encourage all of you to read the IWGDF guidelines, which talks about wound healing in a very systematic manner. So I would like to conclude this talk by saying that it's the responsibility of the surgeon and the physician in this wound healing process. And I'm trying to find out the stop share button. Can somebody stop sharing it?